And our next speaker, it's very difficult to introduce Dr. Mermoud. In short, I would say he's the first glaucoma billionaire of the world. And the best part is that he has pledged his entire wealth for humanitarian service. And you'll be very surprised to know he runs several schools and hospitals in India. And when the last time he visited India, so I asked him, why are you coming? So he said, my daughter is getting married. So this was a school in South India where he had funded, and this orphan girl whose Andrew has brought up, and when she got to marriageable age, so it was Andrew who gave away that child as a father. And so it was very moving for me, all the way from Switzerland, and so much of service he has done. He is, of course, professor at the famous Jules Gonin Eye Hospital. He is the father of non-penetrating glaucoma surgery. He has invented the iWatch implant and trained many fellows, one of the finest surgeons. And I thought there is no symposium MIGS till you have words of wisdom from Andrew. So the topic is MIGS versus MEGS, and MEGS means minimally effective glaucoma surgery. So over to you, Andrew.
Thank you very much, Tanu, first for the invitation to be part of this fantastic meeting, and thank you for the kind words of introduction. My main practice is to treat very advanced glaucoma, because in Switzerland my colleagues send me the very difficult case, and often when they failed MIGS surgery or other kind of surgery, those patients will come to me. And that's why I don't personally do very many MIGS, because my patients are not, MIGS candidates. The same as Tanush said, I'm working half of my time in Africa, where I'm operating a lot of patients, and I can tell you in Africa, it's probably like in a rural area in India, patients don't have much money, patients don't come for follow-ups, and I don't think that MIGS is a good solution for this kind of population. But anyway, I'm going to speak about MIGS. A lot of it has been said already by my colleagues here, and first of all, I want to dedicate this lecture to my very good friend and mentor, Ravi Thomas. I used to work with him. I was a visiting professor in Vellore in 1994. And then I also visited Ravi Thomas many times in LV Prasad when he was over there. Now, the MIGS, I don't want to repeat what my colleagues said before, but you can do so many kind of MIGS. They can be in the angle, they can be in the suprachoroidal space, they can be under the conjunctiva. I'm going to just give you a few words. This is my friend Ike Ahmed. And his ideal glaucoma surgery was to have a pressure of 10 millimeters of mercury, taking just 10 minutes, and which will work for 10 years. So MIGS for minimally invasive glaucoma surgery means, if possible, ab interno approach that is minimally traumatic, at least modest efficacy that is sustained, extremely high safety profile, and rapid recovery with minimal impact of quality of life. This was Ike's words. And if you look at that slide, these are all the MIGS you can find on the market today, and there are so many. They can be either subconjunctival, as I said, trabecular drainage, suprachoroidal, or cyclodestructive procedures. I'm going to just show you a few slides on the results of the most used MIGS today in the world. The Kauk blades, and we saw many beautiful videos, is, as it was said, to rip the trabeculum and to re-establish a good path between the anterior chamber and the collector channels. This is OCT, seeing that the Schlemm channel has been open, and the results are quite good. But if you look carefully at the slide, the mean pressure is about 15 to 16 after 6 months. And if you wait longer, it's about, basically the pressure will be about 15. With not very much complication, as you can see on the right side, a few IOSP spike, a few bleedings, but that's not bad. So the overall reduction is 36%, which is okay if the pressure is 18. But if the preoperative pressure is 35, what we often see in very advanced glaucoma, that won't be probably sufficient. The eye stent is very easy to do. You usually do it after cataract surgery, and then you just plug in those 2 plugs or 3 plugs today. It has been, as it was said, it's functioning quite well. As you can see here, it's easy to do. And it's interesting to see those UBM, the OCT, done by Gilman, one of my fellow, showing that you have an enlargement. If you look on the opposite side, the Schlemm's canal is very small. If you look at the place where the eye stent was placed, you have an enlargement of the size of your Schlemm's canal. So there is efficacy. And in terms of IOP reduction, we got minus 9% of IOP. We could reduce the medication by 72%. So it's very useful if you have early glaucoma and you want to reduce the medical treatment. Interestingly, you can see that if you do post-op anterior chamber angiography, and this was done by our colleague Wang in San Diego, you can see that there is an increase of outflow in the site of your eye stent implantation. The iris, you saw beautiful videos from my colleagues also. It's not as easy to perform as the eye stent, but it's quite easy, and usually we do it after cataract surgery when patients have intolerance of glaucoma medication or slightly higher pressure like 22, 23 in early glaucoma. That's when I sometimes use the iris stent, and the results I'm not going to stay here because you already see so many videos. And I'm going to just give you a few results of the Horizon study, which is a very interesting study because it's a large study, prospective, multi-center, single mask, randomized study, which was done in 556 patients. 1/3 was just phaco alone as the comparative group, and 369 patients had phaco plus iris. So iris was, of course, in every case put correctly. And these are the pressure in the post-op period of 24 months. You can see that the reduction in pressure is about 20%. And this slide is more interesting because you can see that if the blue lines are the reduction of the combined, and then the gray line is just the phaco. And the difference between phaco without iris and the phaco with iris is about 20%. An example, if the pre-op pressure is 20, then it will reach 16. If the pre-op pressure is 25, it will reach 20. And if the pre-op pressure is 30, it will reach 24. And this, for me, is not enough for a patient with advanced glaucoma where the aimed pressure is 10 to 12. Of course, if it's very early glaucoma, you can actually play with these devices. Now, the mini-eject is something new. It will create cyclodialysis and bring the aqueous into the subchoroidal space. And it's a very interesting, promising device. It's quite new. And you saw a beautiful video from Leon, so I'm not going to show you this one because it's not as nice as your Leon. Your video was much better. You picked the best. But I mean, you have to go at the root of the iris, and then you stick in this implant. You can see it here very nicely on OCT of the intersegment. And now I'm going to the GEN. Nobody spoke about the subconjunctival mini-invasive surgery, and the XEN gel has been widely used in the last almost 10 years. So I'm just going to show you now maybe a video. It's the Pozoy law, which is actually used in this principle. You have a 6 millimeters long tube with a 45 to 60 micron diameter inside diameter, and this goes from the antechamber to the subconjunctival space. So this is how you use it. You fill the chamber with viscoelastic. I do a second paracentesis to be able to hold the eye down. I'm injecting mitomycin in the upper quadrant. I'm checking that the XEN is in the deliver system, and then I will put the needle in the angle, aim 3 millimeters posterior to the limbus and come out under the conjunctiva, and then inject the XEN device. Okay? What are the results? Well, my colleague Mansouri has analyzed our results on 129 eyes. Here is the pressure. We had a very small group of XEN alone, which is in dark, and then XEN plus cataract, which is the light line, which shows nice results, but mean pressure after 2 years of 14 millimeters of mercury. And this is it's a good result, but it's not, to me, enough for advanced glaucoma. Adverse events were not so many. A few ifema, very few choroidal detachment and hypotony. So this is quite safe surgery. It's easy surgery to do. As you saw, it takes about 5 minutes. The operation rate is 10%. And one problem is that it will create a very thin, usually quite avascular bleb, as you can see, and then the rate of needling is quite high. Almost 50% of your patient will need a needling after some time. This is 26% at 1 needling, 12% at 2 needling, and 7% at 3 needlings. The blebs don't often look nice, and when you have to reoperate those patients, then it's quite difficult because the conjunctiva is very thin, it's very fragile, and it's very difficult to redo a filtering surgery if you have this kind of condition. Now, more recently, you have the preserved flow, which is almost like a trabeculectomy, but you don't need to open the chamber. The tube will actually replace the flap and replace the trabeculectomy itself. The results are quite good. They basically show the same results as a trabeculectomy. But the surgery needs also to open the conj and then to close the conj. So it's not a big difference. It's really just an easy surgery. I'm not sure that it's really a MIGS. So to summarize, MIGS complications are often lower in comparison with classic filtering surgery such as trabeculectomy or deep sclerectomy. Angular MIGS are more effective in early glaucoma when the downstream system is healthy. Suprachoroidal MIGS and subconjunctival MIGS use added drainage pathway, but the final IOP is in the middle teens, meaning 15, 16s. I normally do deep sclerectomy, which has not many complications and actually has the same low complication as most of the MIGS. And then, in some cases, MIGS might be a good option. As I said, if you have very early glaucoma, if you want to reduce the treatment, the medical treatment, if the patient don't want a major surgery, it's a good option. Sometimes it's not a good option because the results, as you saw this morning, are not optimal when we want to have very low pressure. And this is most of our very advanced glaucoma cases. They need very low pressure. Then MIGS, I don't think it's a good option. And so if I come back to Ike Ahmed's slide, MIGS, are they really ideal glaucoma surgery? Are they bringing the pressure to 10 millimeters? No. Is it a 10-minute surgery? Yes. Will it stay for 10 years? I don't know. Probably not. So don't forget that MIGS also have a price. and compared to standard surgery, they will cost much more money. In Switzerland, all our MIGS cost between 1,000 and 2,000 Swiss francs, which is about 1 lakh to 2 lakhs Indian rupee. And this doesn't include the surgery cost. That's just to buy the device. So it is definitely expensive, and especially if you are working in rural areas where patients can't afford this kind of surgery. Thank you very much for your attention.